Welcome, everyone, and thank you for joining us. My name is Jennifer Silva, Director of Education and Clinical Excellence at Premier Diagnostic Services. And we are so thrilled to welcome you to the first webinar in this series. But before we dive in, I'd like to tell you a little bit about Premier. Premier Diagnostic Services was founded in 1997 with a simple mission to be a trusted partner in diagnostic ultrasound. Over the past 28 years, we've become one of the largest independent providers of ultrasound equipment, staffing, and clinical services in the country, working alongside hospitals, physician groups, and private practices across OBGYN, maternal fetal medicine, general imaging, vascular, and cardiac ultrasound. From that foundation of clinical excellence, Premier Sano CME Hub was born, a webinar-based CME study group approved by the SDMS, because we believe every sonographer deserves access to quality continuing education. This is the first of many sessions to come, and we're so glad you're here from the very beginning. And with that, I am so excited to hand it over to Ellen Murphy with Sona, who will introduce tonight's presenter, someone I've had the pleasure of working with for many, many years. Handing it over to you, Ellen.
Thank you, Jen, and hi, everyone. I am Ellen, the founder of Sona, and I love seeing so many Sona sonographers in this room here in this webinar. For those of you who do not know what Sona is, it is a free way to send images and clips directly from the machine to patient's phone. So as you're scanning, you can just press a print button and send those pretty pictures that you take over to patients. I'm going to introduce Dr. Cohen, and then we'll just get into some housekeeping things for the webinar. So Dr. Bruce Cohen is a board certified maternal fetal medicine specialist, a graduate of Yale University and the University of Pennsylvania School of Medicine. He completed his residency at Beth Israel Deaconess Medical Center in Boston and his maternal fetal medicine fellowship at the University of California, Irvine. He previously served as the clinical assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School, as well as a director of maternal fetal medicine services and division director of maternal fetal medicine. In 2010, he became a co-founder and chief executive officer of Boston MFM, where he helped build the leading maternal fetal medicine practice in his region. He now practices with UMA, a physician-led maternity telehealth group dedicated to expanding access to specialized care for pregnant patients, and is currently a graduate of music and Judaic studies at the Columbia University. He has an amazing biography. He's an amazing person and an amazing doctor. So I'm excited for you guys to hear this webinar on fetal echoes, but a couple things. If you guys have any questions, we're going to have a Q&A session at the end. So feel free to click into the Q&A box and submit the questions in the Q&A box. If you put them in the chat, we'll try to keep up as we go. Another thing, we have so many registered sonographers from all over the country, from all over the US, but also from all different states. So we'd love it if you could take a second, introduce yourself in the chat, tell everyone where you're from, and I think it's great to see where everyone is. So with that, I will hand it over to Dr. Cohen, and we'll get started on the webinar tonight.
All right. Hi, everybody. I'm Bruce Cohen. And, from that introduction, you would think I was older than 40 years old. I was actually going to try and pass myself off as much younger on this webinar, but Ellen and Jen really did me in that regard. So tonight we're going to talk about imaging of the fetal heart. Now, sometimes, people use terms like level 1 ultrasound, level 2 ultrasound, fetal echocardiography, and it all sounds, very official and foreboding. And I don't like to think of it like that. I like to think of we're just imaging the heart. And so we wanted to take tonight a little bit different tact and a little bit of a relaxed tact because I know a lot of you out there um, image the heart every day. And so we're going to try to give you something in this lecture that you can take away and find valuable. So we're going to look at the grayscale imaging, color Doppler imaging, and pulse Doppler imaging of the fetal heart. Now, I wanted to start out with a question, why focus on the fetal heart? For those of us that do this all the time, it's very, very important to be good at imaging and interpreting the fetal heart. It is the site, the most common site of major congenital malformations. Almost 1% of all babies have a congenital heart defect. And that goes across the lines of patients that we call low risk, high risk. They are ubiquitous in the obstetrical population, and it very often is the most difficult part for sonographers and maternal fetal medicine specialists to image. It's moving, the baby's moving, the parts are small. So when we have a limited study, one of the most common reasons why we have a limited fetal anatomical survey is that we can't fully appreciate the fetal heart. Another reason why imaging the fetal heart is very important happened this past week at a hospital that I work at. There was a lack of finding on an imaging. A patient delivered at this hospital, and the baby promptly passed away. It was a community hospital, and they didn't have the bells and whistles to deal with a problem which, if it had been diagnosed, would have led to a person that likely would have lived for 70 or 80 years. So it's a common site of malformations. It's a difficult site to image, and it can prevent death. These are occasionally life and death situations. Now, to take home and to remember, the incidence overall of heart defects is about 1%. That's just the easiest way to remember. And you can see from this picture that about a little more than a third of all heart defects are ventricular septal defects. And these often aren't even treated. Some of them close on their own. Some of them are easy to repair, and some of them don't even require repair. And you can see that less common are a bunch of other diagnoses. But one of the things that I want you to appreciate to make you feel more relaxed about looking at the heart is that there are a finite number of reasonably common abnormalities, so that if you can learn to appreciate this finite number, you are going to be well equipped to image the fetal heart. Now, some people are more likely to have a heart defect than others. If you have diabetes, if we look at the entire diabetic population, they are 5 times as likely to have a congenital heart defect with their baby than the general population. Patients that are obese, patients that had IVF pregnancies, about that same rate of fetal malformations, about 4%. And there are other features, not a lot of other features. Most of the people that are diagnosed with having congenital heart disease are having a so-called level 1 or low risk ultrasound. That's why it's so important for every obstetrical sonographer to be familiar with the fetal heart. It isn't about a high-risk population. It's about all pregnant women. So I wanted to take a little bit of a look in a little unorthodox way at cardiac anatomy. And to do this, I want to look at some cadaver specimens. So if you're going to be nauseous, now is a good time to block out your screen. But I want to get an appreciation of how this heart sits in the body and what it really looks like, not on an ultrasound screen. So in this first picture, I want you to imagine you're looking directly facing the person in this picture. And in the top of the picture, you can see the person's neck right here. And this is their right lung, and this is their left lung, and this is their heart. So we're staring right at this person face to face. Now, if you want to, message in, what are we looking at? What part of the heart are we looking at when we are staring at this person? So feel free to message in if you want to comment. But I'm just going to go ahead and tell you that the part of the heart that we're looking at is the right ventricle. This whole thing basically is the right ventricle of the heart. And in the back, we can see a little bit of the right atrium. But we can't see the left part of the heart at all when we just face somebody and look at their chest. So if we had X-ray vision and we're looking at their chest and we're looking right through them, we are looking at the right ventricle of the heart. And in this also a picture of a cadaver, and we're now looking at a cross-sectional view that's going to be more familiar to you. This is the spine, and this is the sternum. And we can see, I want you to get a certain appreciation of how the heart sits in the chest. So what we can see is that if we're looking at this person from their front, the whole thing that we're seeing is the right ventricle. And we can see that kind of deeper in the chest is the right atrium. If we're standing in front of the person and looking at them, we won't see the left ventricle or the left atrium that hides behind them. But if we're standing behind the person looking at their spine, we're going to see the left ventricle and the left atrium. So just to get an idea, we talk about the axis of the heart, but it's very pronounced. It's almost all the right ventricle in the front view and almost all the left ventricle in the back view of the person. And we can see that the heart is cushioned by the lungs. The left lung only has two lobes. It's smaller than the right lung, a bit of which is cut off in this picture. The right lung has three lobes. And so the heart fills about 1/3 of the chest cavity, sitting on the lungs and leaning heavily to the left. We can also see that the left atrium sits right over the spine. This is going to be very important to understand how the heart sits when we're thinking about performing an ultrasound on the heart. And if we look at this cadaver specimen, which is slightly rotated, again, the right ventricle is in the front. The gray is the left ventricle, which we can barely see. And we're looking here at the right atrium. And we can see that the superior vena cava and the inferior vena cava, they're all about the right atrium. So when we're staring at somebody's chest, we're staring at their right ventricle, and slightly posterior is their right atrium with the superior vena cava and inferior vena cava associated with that structure. And here is the right ventricle again. Okay, we're standing here in front of the person. We're looking at their chest. We're seeing all right ventricle. Now, one of the things I want you to realize is that the right ventricle has a unique appearance. It has this papillary muscle right here in the middle that distinguishes it from the left ventricle. So when we look at this, we see this is what the right ventricle looks like. And in this picture, again, we can see the lungs. We can see that the left atrium lies right over the aorta and the inferior vena cava. And these are two very different vessels. This is a thick-walled pipe, the aorta, and this is a compressible, floppy inferior vena cava. And also note, here's the spine. The aorta and the inferior vena cava, they lay directly on the spine. Now, as I said earlier, if we were standing behind the person, we would see the left ventricle and the left atrium. And we really wouldn't see the right ventricle at all. So if you're walking behind somebody and you're looking at their back, and you had X-ray vision, you would see the left ventricle and the left atrium. And you would see the pulmonary artery coming out of the right ventricle. It's coming back at you. But the aorta coming out of the left ventricle is coming a bit forward. So we're standing in back of the person, in back of their aorta and their inferior and superior vena cava. And we've got the pulmonary artery coming back to us and the aorta at first going away from us. So we're thinking about now, how does this heart sit? Now here's another cadaver picture, and now we're sort of standing on the person's head, looking down at the heart. When we look down at the heart, we can see the right ventricle in the front of the person, the left ventricle in the back of the person. Now let's think again about how these outflow tracts actually look in a person. So if you were standing in front of the person, you would be looking at the right ventricle, and the pulmonary artery, the right ventricular outflow tract, is going directly back towards the spine. It's going directly away from you if you are standing facing the person. Whereas the left ventricle in the rear that you don't see standing in front of the person, its aortic arch, okay, the left ventricular outflow tract, it's coming straight or forward. So the right ventricular outflow tract is going backwards towards the descending aorta and the inferior vena cava, while the left ventricle is going east-west. The left ventricular outflow tract goes north-south, but the right ventricular outflow tract goes north-south. It's going directly south, whereas the left ventricular outflow tract is going east-west. I know this is a bit confusing, but if you want these images, it's very interesting to look at these and to begin to understand really on an anatomical level what we're really looking at, because it's really going to help us when we go to look at our ultrasounds. And here's a picture. Here's the right ventricle and the left ventricle. The right ventricle has the right ventricular outflow tract, the pulmonary artery. It is coming directly back towards us, towards the descending aorta. But the left ventricular outflow tract is going east-west. It's going up and around, and now it's going to go back towards the aorta and inferior vena cava, and it's going to meet the right tract through the ductus arteriosus. So both of the tracts have to go back to meet the descending aorta, but the pulmonary outflow tract goes right straight backwards through the ductus arteriosus, and the left tract goes to the ascending aorta, moving forward before it goes backwards. And this view is, I think, a little bit confusing, as if you weren't confused enough already. Um, but really, the four-chamber view really is sort of looking like this. It takes into account the right ventricular outflow tract and the right side of the heart here. It takes into account the left side of the heart here, and it's grabbing the atria as well. We won't get too confusing with that. So Now, we looked at a lot of cadaver images, and we may be thinking about the heart, we may be totally confused, or we might be thinking about the heart in a different sort of way as to how it sits in the normal chest, depending upon whether we're facing the person, viewing the person from the back, or viewing the person from the side. Because the baby could be in any position when we do ultrasound, we need to think about how the normal heart sits anatomically. How does it sit with the lungs? How is the axis tilted? So now we're going to move to fetal ultrasound, grayscale, color Doppler, and pulse Doppler. And we're going to use each of these to better understand the fetal heart. We need to take advantage of all of these. Grayscale is going to offer the best view of the anatomical details, the fine details. Color Doppler is going to demonstrate the presence and the direction of blood flow. One of the main things we're going to do when we look at the fetal heart on ultrasound is track how the blood is flowing and where. Pulse Doppler is going to provide us details regarding the timing. Like when we want to measure the baby's heart rate, we can use pulse Doppler to see when blood is flowing, as well as the amount of flow. We can even calculate the gradient of flow across valves and the speed of flow using the pulse Doppler. Now, the first view that we want to think about is visceral situs. And I want you to think of this image on the left, just as we had that cadaver image. Very similar, okay? And we're going to see the heart with the left atrium right over the aorta. And we're going to see the heart tilted. If we made a X here across, the heart would be at about a 45-degree angle to the horizontal. And we can see the four chambers, and we can see, I want you to assume that this baby's in the vertex presentation. We can see that this heart is angled to the left. Now, if we scan down this baby, we're going to find the stomach below the heart on the left. And that's going to tell us our directionality. We have a heart that points to the left, and we have a stomach that sits on the left. And this is very, very important because a lot of abnormalities are going to play with things that are wrong with the position of the heart. And we're going to see that the umbilical vein comes in to the body and curves through the portal sinus away from the stomach, going into an organ that is the liver. And we're going to see that the liver is slightly darker than the lungs, and that this portal sinus is going to take the umbilical vein, connect it to a structure called the the ductus venosus, and that's going to connect with the inferior vena cava and bring that blood into the right ventricle of the heart. So this is showing the positionality that the heart is in the middle of the chest, pointing to the left side, that the stomach is also on the left side, and that the umbilical vein goes in away from the stomach through the portal sinus to the ductus venosus. And in real life, the baby could be in any position or it could move during the examination. So we have to appreciate this four-chamber view of the heart in different positions. Here is the baby lying on its back. We can see the spine back here, and the heart is pointing this way in the vertex baby. Well, if the baby is vertex and the baby is lying on its left side, the heart might look like this. And if it's laying on its right side, the heart might look like this. And if it's kind of at an oblique angle, the heart could look like this. So we have to get used to seeing this four-chamber view of the heart, no matter what position we find that the baby is in. Now, the four-chamber view of the heart can diagnose the vast majority of heart defects alone. So let's look a little bit at the four-chamber to see the anatomical features. And one of the things that I want to emphasize to you that all four chambers have a distinct appearance that you should take note of when you're looking at the four-chamber view of the heart. The right ventricle is distinguished by the papillary muscle. There is no other chamber of the heart that has a papillary muscle. We also can see that the tricuspid valve leading into the right ventricle inserts just a hair lower in the heart than the mitral valve, which leads into the left ventricle. So the right ventricle is that critter that has a papillary muscle and the slightly lower tricuspid valve. The left ventricle of the heart is that beast that has a little bit of a thicker wall, no papillary muscle, and the slightly higher up mitral valve. Now, the right atrium of the heart is the one that looks maybe a touch larger because of the downward displacement of the tricuspid valve. And the left atrium is that critter that has the pulmonary veins going into it. So this is a little like a Mickey Mouse hair, okay? So the left atrium is the critter with the pulmonary veins, and also because in the normal heart there's shunting of the blood from right to left, you will see the foramen ovale bulging and the valve pulling into the left atrium. So the right atrium and left atrium do not look like each other. The right atrium has the displaced down tricuspid valve. The left atrium has two pulmonary veins going into it and the upwardly displaced mitral valve. The right ventricle has the papillary muscle, the left ventricle does not. So each chamber of the heart has its own particular look. Now, we go from grayscale to color Doppler, and this image shows us that the mitral valve and tricuspid valve open during diastole, allowing the blood to flow, as shown by the color image here, from the atria to the ventricles. It's also a great way of looking at the intervertebral septum, and we can see the directionality. During diastole, the blood flows in a similar direction into the right ventricle and into the left ventricle. And we can use pulse Doppler to tell us a little bit about our valves and the flow of blood. These are called the E wave and A wave, and this is a ventricular contraction. If you place your Doppler just inside the left ventricle of the mitral valve, you will see this characteristic appearance. And we use this in patients with Sjogren's syndrome to actually time how long from the atrial contraction to the ventricular contraction. But this is a way also of showing the normalcy of flow through the mitral valve. This is the normal appearance of flow through the tricuspid valve. So we can look at both of these valves and look at their flow as a means of establishing their patency beyond the color Doppler imaging. This is the so-called five-chamber view of the heart, looking at the left ventricular outflow tract. In the grayscale, which is the best at looking at fine details, we can see the aortic valve. And so it's difficult to see when the valve isn't moving, but if you are watching this in real time and with grayscale imaging, this shows a beautiful interventricular septum, and we can look at that aortic valve and watch the blood flowing from the left ventricle into the aortic arch. Now, when we put on color Doppler of this same view, we see really another role of color Doppler. And why is it that as the blood flows out of the left ventricle, it's this dark blue color? When it goes through the ductus arteriosus, we see a bright blue color. And when it turns and goes down the descending aorta, we see it as an orange reddish color. The reason is we are seeing the directionality of flow. As the flow moves east-west out of the left ventricle, past the aortic valve, into the ductus arteriosus portion of the left ventricular outflow tract, it changes direction. We have the aortic arch. And so what we're seeing here with the color change is the change in direction. When it enters the descending aorta, we're now going south down the body. We've changed the direction of blood flow. So this arch and flow of oxygenated blood out of the fetal heart has three different colors in the normal fetus. And if we look at the aortic valve, it has a typical appearance. Now, when we look at the right side of the heart, we see the pulmonic valve right here. So we go to grayscale and we look at the pulmonic valve, which we can see moving in real time. And then we can see the division of trunks right here and the aorta in cross section. Okay. And if we looked at the pulmonic valve with our pulse Doppler, it has a typical appearance. So we can look at structures on the gray scale, and we can look at their fine details. We can look with color Doppler and see how the blood flows through structures and the directionality of flow, which you can see right here with the ductus arteriosus. You can see the right pulmonary artery, and you can see the aorta, and they're all flowing in the same direction here. But this vessel is the superior vena cava, and this vessel is flowing in the opposite direction. It is draining the venous blood from the brain. It is descending down the tract into the right atrium. This is a different direction, so that the normal color image of the right ventricular outflow tract shows this blue color going to the pulmonary artery. As we enter the ductus arteriosus blood and the change of direction, it's the lighter blue color, and the superior vena cava with the blood going in the opposite direction, that's going to be the reddish color. And this is the pulmonic valve and what it looks like. Moving up slightly, we can see the so-called three-vessel tracheal view. This is the pulmonary artery meeting the aorta at the ductus arteriosus and the isthmus of the aorta. The superior vena cava draining the blood. We know this is going to be a different color than these characters. And we might mistake this for a vessel, but not if we put on color Doppler. This is the trachea. It's not a vessel at all. It has fluid in it, so we may not be able to distinguish it from a blood vessel, But what we can see here, here's the pulmonary artery becoming the ductus arteriosus. Here's the ascending aorta coming up to join at the isthmus. And here's the superior vena cava, which the blood is going in the opposite direction, draining the brain. And you don't see anything lit up here. That's the trachea. And we can see another image of this here. Again, so clear, the blood flowing. And here's the trachea with no color on it. It's not a vessel. And we can see here, just to go over, this is grayscale image of how the blood goes back from the right ventricle, it goes directly backwards to become the descending aorta. That's the aortic arch. And we can see this and how it becomes a little bit more turbulent at the isthmus. And here's the descending aorta. Here's the right ventricle. And you can see again this long backwards move of the blood to join the ductus arteriosus here at the isthmus. And here's the descending aorta. On the other side, here's the venous side. Here's the superior vena cava, which we saw in orange before, draining the venous blood from the head. Here's the inferior vena cava, taking the blood from the ductus venosus and the umbilical vein and bringing that to the right atrium. Now, we were talking the umbilical vein blood comes into the baby through the umbilical vein, and it meets the ductus venosus, which is then going to turn this blood through the portal sinus in the liver to join the inferior vena cava that then goes into the right ventricle of the heart. And this is a very important tract, and you can use what's called aliasing using colored Doppler. At the end of the umbilical vein, when you see the aliasing, that is the ductus venosus. So you can see in your patients the presence of a ductus venosus. Very, very important for you to identify. Here on pulse Doppler, we can see what's called the S wave, D wave. It's this biphasic wave that identifies that, yes, you are on the ductus venosus. Okay, so enough boring you with the anatomy of cadavers and enough with all these grayscale color and pulse wave images. It's now time to play your favorite game show, Name That Issue. So if you are like the kid that sat in the front row of the class and you have to name that issue, well, chat that right in, and Jen is going to tell me. And, I don't know if Jen, if there's any prizes, probably thousands of dollars here that Premier Diagnostics and Sonar want to give up, to those of you that can identify the structures. Maybe not. Maybe not. Okay. So this shows three different problems with the heart. And so if you want to message in, go right away. And I'm going to pretty much go ahead, if that's okay, and say what's going on in these images. So,
Bruce, we have someone that said CPAM.
okay,
Amen.
that is a very good thought. And it may be that you are correct, Jen. Check for $1,000, okay? So
Oh, there it
what we're
goes.
what we're really looking at in these three images, which can be the result of a CPIM, is the different positions. Remember the cadaver. Remember how that heart sits in the chest. Remember that the spine is here, but we're not really sitting over the left atrium. This heart is too much to the right. And one of the main reasons why you'll see a heart that's too much to the right is a CPAM, a congenital pulmonary artery malformation. In this case, I don't really see a CPAM. There can be other reasons for that, but we can see that this heart is too far to the right. What about this heart? This heart, instead of, here's the spine, the baby's lying on its right side, but instead of being angled up like this, we see that the heart is on an axis of 0 degrees rather than 45 degrees. Maybe that's a CPAM right there, but this heart has an abnormal angle. What about this heart? This really isn't a CPAM, but this heart, here's the spine. The, it is true that the left atrium lies over the heart, but instead of having a 45-degree angle to the spine, this heart is massively tilted to the left. And this is associated with a lot of heart abnormalities. So one of the things that I want you to feel at the end of this lecture is not afraid of the heart. There really aren't that many abnormalities. We're going to go over a lot of them in these few pictures coming up. If you can just sense that cadaver and say, how should this heart be sitting in the chest? You're going to be able to diagnose a lot of malformations. In these three pictures, the heart is not sitting properly in the chest. Okay, who wants to win $1,000? Do you got anybody, Jen?
I had someone write in that said mesocardia for the
Oh,
last slide
okay,
as a guess. Let's see what else. Oh, so I have some, they're coming in now. Pericardial effusion.
there you go. So this is a pericardial effusion. You may see in a normal heart the dependent side of the heart with a little effusion, but when you see fluid around the heart, that is abnormal. That's a pericardial effusion. And if it's greater than 4 millimeters, certainly this is going to be abnormal. So we're not even really looking at these fine details about the heart. We can see a lot that's abnormal just by getting the view. What's all this fluid doing here? How is this heart lying? Okay. This is another example. Okay, thousands of dollars are at stake here.
You're gonna get me in trouble with this one. I have someone wrote in hernia, someone CDH diaphragmatic hernia.
Right, that's what this is. Jen has a lot of money. She's going to make out the check. Uh,
Oh
so,
no.
so when you saw those cadaver images, you did not see the stomach in the same picture as the heart. So again, this baby is vertex. The left atrium should be over the spine, and this heart should be pointed this way, but it's not. This is dextrocardia. The stomach has entered the pleural cavity. This is a congenital diaphragmatic hernia. And when I told you about the case last week where a baby that could have lived a full life died in the delivery room, it's because it was missed that there was a congenital diaphragmatic hernia. Now, here you see again, pushing the heart to the right, you can see the stomach on the left side. And so that picture we saw of situs would be off here because the stomach is in the thoracic cavity. Now, in this thoracic cavity, you see lung tissue, and you can see some lung here on the right side. But this doesn't look like lung. What's this? This is intestines. There's stomach and intestines in this baby's chest. So if the baby is born and we don't know about this heart is going to be compressed. This baby is not going to be able to survive well outside the womb. And this is why we have to care about what does that heart look like? How does it sit in the chest? Because we don't want to miss a congenital diaphragmatic hernia. Okay, this is a fun one. I'm
Let's
hoping
see.
that this picture, which I can't see behind us, is visible to our audience.
So I have a pleural effusion as the first.
That's
I have
absolutely right.
hydrops.
This group is going to be hard to stump. That doesn't mean
Yeah.
I'm going to try, but it's going to be hard to stump. These are pleural effusions, so there's no pericardial effusion here. This baby is vertex, beautiful access of the heart, four chambers, gorgeous. This, we see the pulmonary veins coming into the left atrium. We see the papillary muscle on the right ventricle and the slightly thicker left ventricle, but there's fluid around this heart and very little lung space. This is a pleural effusion. Okay. All right. Jen is now hawking her wedding ring. Okay.
Gonna
For
go up
this
for
one,
sale soon.
right, exactly. You got anything on this one, Jen?
CPAM.
CPAM, right. This is a classic CPAM, and you can see the dextrocardia. Again, here's the spine. The heart is way over in the right chest. See, we haven't even really looked that much at the heart yet, and we're diagnosing all these important things because diagnosing a CPAM can be a life or death diagnosis. And you can see the CPAM in the longitudinal view here. But this is a mass in the left lung, a large mass, which can have the ability to compress the heart and cause cardiac failure and stillbirth, or alternatively, resolve. Okay, this is one of my favorites. This is the old good news and bad news.
The premier sonographers should know this. I just shared this interesting case with our group. Cardiac ectopic cordis. Yep.
Right, this is a heart
Perfect.
that's sticking out of the chest. So, if you had this, you might say, to the patient, I have good news and bad news. Look at the beautiful face, the lips, the small nose that I can only dream about, and the great forehead. This is a great looking face, but the baby's heart is outside the chest, and you can see in a cross-sectional view, the ventricles are swimming in the amniotic fluid. You've got ectopia cordis. Not that hard to diagnose. Okay.
Okay. Let's see. They're starting to come in.
The RV is now being put up for auction.
Rhabdo.
Rhabdomyoma. So here,
Mhm.
you don't have to be a wizard to know that there's a big Goomba in the left ventricle of this heart, and that's a rhabdomyoma. Those can grow so big that you can impair and you can have no flow out of the left ventricle. You could have a stillbirth. Alternatively, this is a very treatable condition, and there's medications to shrink these. Most of these babies don't need surgery. This is a very doable situation when you diagnose it. Okay, we're getting a little harder now. Jen is putting up the 72-inch television.
My car at this point. Let's go. So we're just waiting. Oh, let's see here. So I have HLHS, hypoplastic left.
Right. Okay, Jennifer's car is gone. This is
Gone.
hypoplastic left car syndrome. What kind of car do you have?
Oh, just, just a little something.
Okay, let's
It'll
explain.
make up for the payment I need to send to everyone that's doing so great right
Right,
now
the
on the
person
panel.
that picked off hypoplastic left heart is an
Yeah.
ultrasound jock, and you can see a beautiful right ventricle. Okay, this baby is breech, and a beautiful right atrium. You don't see much of a left ventricle. You don't see much of a left atrium, and you can see everything's on the right. Very little color flow. This is a great place where color flow makes the diagnosis for you. Okay, now because Jennifer's house is in the mix, I want to know what chromosomal abnormality this baby has.
Oh, that was everybody's coming with what it is, the atrial ventricle defect. But everyone's saying trisomy 21.
Okay, where do you live, Jen? You don't have to give the
No,
address.
I'm not selling my house
All
now.
right. Look, these people are good. So, an
Yeah,
atrioventricular septal defect, you can see that there's just space here. There's no intraventricular septum. There's no atrial septum. There's very little in the way of a mitral and tricuspid septum. This is a major hole in the heart. This is highly, highly associated with trisomy 21.
excellent job, everyone.
Okay, what's this?
Let's see what's coming in. Aneurysm is
Right.
what I'm seeing.
This is a
Yeah,
foraminal
a
aneurysm.
foraminal valley
This
aneurysm.
is a developmental thing. A lot of these babies, the vast majority, this is going to be a normal finding. We note it. Sometimes, if we're very aggressive, we do a fetal echocardiogram. We look for other abnormalities. But in generally speaking, this is a normal finding because there's a shunting of blood left to right in the normal fetus. Okay. All right. This is the vacation home. Jen has a house on Cape Cod.
No, I do not. Don't lie to the group. We want them to come back.
I told a falsehood.
So, okay, let's see here. Right-sided AO,
Right.
aorta.
Right-sided aortic arch. Okay.
Mm-hmm.
So normally
Right
in a
arch.
three-vessel tracheal view, the aorta and the pulmonary artery are on the same time. They converge at the ductus arteriosus, and the trachea is off to the side. But in this view, the arch is going way off to the right and meets the pulmonary artery on the other side of the trachea. This is a right-sided aortic arch, not a terrible abnormality, but one that's good to point out. Okay, ignore this cystic mass. This is much simpler. This we're really just looking at this and at this, and this is just Jen's bicycle. It's a
That's about right. So I'm getting a VSD.
right. That's really all we were after here.
Perfect.
Okay, what have we got here?
Let's see. Coarctation,
Okay,
atresia,
those of you that can
narrowing
read.
isthmus.
Okay,
Mhm.
great. So remember that cadaver image where the pulmonary artery and the ductus arteriosus, it's going straight back and it is met by the ascending and then starting to the descending aorta. It all comes together at the isthmus. And there's a common cardiac malformation at that point where there's a narrowing where they come together, and that's called coarctation of the aorta. All right, now
What
we
am I giving up now?
ah, I cannot
So I
even
have
say.
tetralogy of Fallot, truncus. Let's see. Yep, truncus,
Okay, we want to. Do we have the
tetralogy
name?
of
Do we have
Fallot.
the name of the
Mhm.
person that called this a truncus?
We do.
But they may not want to be mentioned.
Right. So we'll
Certainly
cite.
not by the likes of me. Do they want to be mentioned? Okay, this is a truncus arteriosus. Now, the person that guessed tetralogy of Fallot is a jock too, okay? But what separates these two things is that a truncus is, during embryology, the aorta and the right-sided part of the heart, the right ventricular outflow tract, they didn't diverge. They didn't canal off. So all we have is one vessel that's both the left ventricular outflow tract and the right ventricular outflow tract. And then we have the superior vena cava. So in the three vessel view, grayscale view, there's only two vessels, okay? So we see the overriding aorta, which we would see with tetralogy of Fallot. We don't really see, this looks pretty good size. It isn't that the right side of the heart is atretic. We just have one vessel leaving. Now, if we didn't have the three vessel view, my first inclination would be to say this is a tetralogy of Fallot because that's more common. We have the overriding aorta, and I'm going to look for that tiny right ventricular outflow tract and pulmonary artery. But when we find on the three vessel view that it doesn't exist, that all we have is the superior vena cava and this big vessel, which is both the left and right ventricular outflow tracts, that's a truncus arteriosus.
Bruce, someone's asking, is that a pretty rare, is it pretty rare to see?
I saw one today.
Thank you.
Okay, another doozy. Forget the left image here. Too crazy. Let's just look at the right image.
Yeah, Epstein.
This group. Okay, you're hired. Okay. We know
Yeah.
that the mitral valve should be lower. Okay. It should be here. Here we have a depressed tricuspid valve, and this valve probably doesn't work too well because look at the size of the right atrium. Epstein anomaly is a badass anomaly, and there's a lot of defects that over time develop with this. This is a very bad thing to have. Does the person who came up with Epstein's want to tell us what medication is associated with Epstein's anomaly?
See, I'm getting lithium.
Right, you get the family dog.
Hmm.
Okay. All right. What do we have here?
Someone in the chat said their sister was born with that. I'm just waiting.
And their sisters,
Okay,
right?
persistent left. Yeah, this is a persistent left superior vena cava. Yep.
That's right. So it's coming. The superior vena cava should come from the right side so it can go into the right atrium. But when it comes from the left side, like the lovely sister, I just want to know, is that sister more successful in life than the person that wrote in? Can she answer? Because this is not a bad abnormality. No,
She said no.
not more successful, but healthy and well at least, right?
Let's
So
see.
not a,
Oh, she didn't end up making it. I'm so sorry, Deborah.
this is
Yeah.
very, very
Yeah.
unusual because Deborah, this anomaly usually sometimes isn't even repaired. And one of the things that, one of the reasons why is because we have something, the coronary vessel.
Oh, Bruce, you know what she's saying? It's the Epstein anomaly is what her sister had.
Oh, yes. The
Yeah.
Epstein anomaly. This is a terrible, terrible, terrible thing to have. This is really common with Epstein anomaly, even if your sister wasn't that, it wasn't that long ago. We have a lot of trouble taking care of people with Epstein's anomaly. But the people that have the persistent left superior vena cava, very often this isn't even repaired because there's this way across the heart, and you'll see this coronary vessel that takes the blood from the left side, draining the head, and brings it to the right atrium. So these two pictures are of the same heart. Okay, here we go.
Let's see. TGA.
Right.
Yep.
So one thing that we emphasized before is that each ventricle looks, each chamber of the heart looks different, so we can identify it. Here is a baby who is breech. so that this heart is pointing to the left. This is the left ventricle, the right ventricle, the left atrium, and the right atrium. Okay, so what does this look like, though? Here's a papillary muscle. This is supposed to be the left ventricle. Left ventricles do not have papillary muscles. Right ventricles are not the thick wall ventricle. Okay? So what we see is that these ventricles are reversed. Now, thank God in this baby, there's a ventricular septal defect. Because if it wasn't, and the baby was born, having the right ventricle go to the aorta and the left ventricle go to the pulmonary artery is a death sentence. So this is one of those things, like congenital diaphragmatic hernia, that you don't want to miss. And you don't want to miss it on your level 1 ultrasound any more than you want to miss it on your level 2 or your echo. So if you are scanning women, this is something to look for, something to ask yourself. Does the left ventricle look like a left ventricle? Does the right ventricle look like a right ventricle? What about the atria? We know that the left atria should be having hepatic veins coming into it. Is that the left atria or the right atria? Is the heart pointing in the wrong direction? How are we just sitting here? If we can just view how this heart sits, where the ventricles and atria are, we're going to pick off all of the major abnormalities. I'm just going to go right ahead and save Jen some money and say that this is a persistent right umbilical vein. So a lot of you are very familiar with this. The umbilical vein should point away from the stomach, not towards the stomach. And the reason it points away is that it's going into the portal sinus to join the ductus venosus, to join the inferior vena cava, to go into the right atrium. That's just normal, okay? But that is not what this baby does. This baby has a persistent right umbilical vein. Now, all of you are saying, oh, so what? I see that all the time. No biggie. Sometimes it's associated with heart defects, but if I have a PRUV and the heart looks normal, what the heck? Okay. But there is a condition associated with a persistent right umbilical vein that you must look for because this baby is in deep doo-doo. This umbilical vein comes in, okay, and it is a persistent right. And what it does is it doesn't go into the fetal liver. It comes up, it bypasses the portal sinus. It doesn't go around here. It doesn't have, this baby doesn't have a ductus venosus, okay? This umbilical vein, here's the inferior vena cava, here's the right atrium, here's the superior vena cava. It goes right from the umbilical cord into the right ventricle of the heart. If you got this, you got a problem, okay? Because it is going to flood that right atrium. Excuse me if I said ventricle. This is going right into the right atrium, overloading the right atrium. This baby is going to go into cardiac failure. You do not want to be born without a ductus venosus to shunt the blood through the liver to the inferior vena cava. You do not want this setup. This is not good. And so if you found this in a live baby, you might think about watching this baby super closely or delivering this baby because that setup's no good. So if you see persistent right umbilical vein, make sure you trace where the umbilical vein is going. If you can prove by that aliasing that there is a ductus venosus or show by that biphasic pulse Doppler, you're in the clear. PRUV, no problem. Okay, I'm just going to go ahead and say this one. You can see that this right here, this tricuspid valve is super thick. You can see that the right atrium is super big, and on color you can see Jack is going into the right ventricle. Everything is staying in the right atrium. This is tricuspid atresia, tricuspid stenosis. Same thing here, thickened valve. This is similar to what we have. That's that coronary vessel. That's the right, persistent right superior vena cava, persistent left superior vena cava. This is to point out that you don't want to have in your three-chamber view 4 vessels. No, no. Okay. Superior vena cava, aorta, pulmonary trunk. What the heck is this fourth? It's a persistent left superior vena cava. Okay, what's this?
See, anybody? Tetralogy of Fallot.
Right, so you have the overriding aortic arch going straight out of the heart. This one has a pretty good right ventricle. And you can see not a terrible right ventricular outflow tract, but look at the difference in size between the aorta in caliber. These should be about the same size. You can see this is over twice the size of this. So this is tetralogy of Fallot, overriding aorta, right ventricular atresia, small right ventricular outflow tract. Typical. What are the key points to take home tonight besides all of Jennifer's wealth? We're saying that to become adept at scanning the fetal heart, you need to kind of know the anatomy, getting a feel for the position, how the heart sits in the chest, what else is in the chest, what are the sizes of the atria and ventricles, and what do each of them look like? Start when you look at the heart at the position, axis, and gross appearance of the heart and the thoracic cavity. Then appreciate these normal anatomical features in 3 different modes: grayscale, color Doppler, and pulse Doppler views, using the advantages that each of these views provide. And finally, study the anatomical appearances of a finite, it's not that many when you think about cardiac malformations. If you can just look and get a feel so that you can form a pattern recognition for the few cardiac malformations that there are, then you're going to be a cardiac jock. You got to have heart.
I love that. Thank you so much, Dr. Cohen. We have a little, we went a little bit over, but it was so well worth it. There was a lot of great images to go through, a lot of abnormalities, and we truly, truly appreciate your time. Dr. Cohen, I know you have a lot on your plate. This is a very well presented webinar. I know I learned a lot this evening. I hope everyone out there did as well. We're getting so many thank yous in the chat. Everyone's super excited, and we appreciate the participation from each and every one of you that participated. I'm so sorry if I didn't call you out by your name during the chat, but I saw everything and all the participation. We look forward to seeing you during our next webinar, because this isn't it. We're lucky enough to have Dr. Cohen kick this off for us in the series, and we hope that everyone has a fantastic evening. I will give some time, maybe a minute, if anyone can drop in a question in the Q&A box now. We will give that person time so Dr. Cohen can answer at least one question before we end this evening. Let's see. Oh, you're getting a bunch of thank you, great cases, and explanations, Dr. Cohen.
We will
Okay, so
also make sure to send the recording out. I know someone asked for
yeah.
the slides, so you guys can look at the presentation again.
Yep, and you'll receive the CME in a few days. But I don't have any other questions. I'm not seeing anything. If anything does come up, feel free to email Ellen or myself, and we can see if Dr. Cohen is available, and we'll get the answers for you. Thank you so much, everyone. and have a great evening. And again, thank you so much, Dr. Cohen.
So welcome.
Thank you,
Thank you.
guys.
Good
Thank you,
night.
Dr. Cohen. Good
Bye.
night.
Bye.